Why don't we, got it, okay. Why don't we go ahead and get started? It is my pleasure to introduce today's speaker, and that is our very own Dr. John Sauceda. John is a health psychologist, and he is assistant professor in the Division of Prevention Science. He is also co-director of the UCSF CFAR mentoring program, and also co-director of the developmental core for the Center for AIDS Prevention Studies. He is MPI of the NIDA-funded Summer HIV/AIDS Research Program, SHARP. It's a mentored training program for aspiring researchers. He has two distinct lines of research. One of them is focused on HIV care and treatment disparities among Latinx people living with HIV, and the other is related to the social and ethical issues in HIV cure research. He is building on a National Institute of Mental Health, KO1, in which he's been designing an adaptive intervention for Latinx people living with HIV with depression who receive care at Ward 86 clinic. He has two new R01s, and I believe that is what he's going to be telling us about today. So I am going to turn over the Zoom mic to John and let him tell us about all the awesome things he's been doing and what he's going to be doing. Thank you.
Thank you, Mallory. And also thanks to Rochelle and Stuart for organizing, and everybody here for this Monday afternoon talk. Different time, but I appreciate everybody showing up here. So let me see. Can you all see my slides? Are we good? Oh no, we're not, because I didn't share my screen. Sorry.
No, don't worry.
All right. Is that
looks great, John?
Okay, thanks. All right, so here's an outline of what I'll be covering. What I wanted to do was do an introduction to this work and how I got to the two latest new projects. And so you really, I was very intentional with the title because in reflecting back, this work is really a reflection of the blending of these three areas of training that I get in. And one of the questions as Mallory as well always gets asked is, what is a health psychologist? And so what we do is we take different areas of psychology and principles and methods and apply those to how we understand a person's health or illness. In my training in clinical psych, we take the science, theory, and practice of assessing psychopathology and then try to intervene and treat that. The idea is to promote adaptation and adjustment. And then with quantitative psych, which is kind of the underbelly of all of my work, it's about the statistical methods that we use and the techniques that we use to measure human behavior, which obviously most of the time we're not there to witness. But I think more interestingly and more challenging scientifically is, how do you measure these psychological processes that, not only are you not there to witness, but they're occurring in someone's mind, and how do you measure that, and how does that affect someone's health? So in thinking about my approach, which was the title, it's the application of those three areas of psych to thinking about issues of retention, adherence, viral suppression. And one line is particularly around Latinx mental health, Latinx outcomes, and really the promotion of this population and research in Spanish, I think, is critically important. And that directly ties to the quantitative tools that I like to use, which are about, if you're going to do something in Spanish, is it valid? Does it represent the construct that you're trying to measure? SEM is just basically a fancy way to do multiple variable regressions and latent constructs analyses to look at things like depression or stress or stigma. Again, you can't see these things, but we know they're occurring, and we're trying to measure them as robustly as possible.
So John, what does SEM stand for?
Oh, sorry, structural equation modeling.
Thank you.
Also, I think too, though, that in the evolution of this work, I think it's really important, as I've the more and more I read and the more and more I get inspiration from sort of leaders in this space, like Ruth Zambrana and our colleague Jesus Ramirez Valles, about it's not just the cold application of those principles or these scientific methods to these health outcomes, right? Because we know that Latinx people or other health disparities are socially and structurally constructed, but yet we don't have investigators of color trying to solve these problems. in the numbers that we want to have. And so I think it's just important to talk about, I'm from a minority serving institution. I'm a Chicano psychologist. Spanish was in the household, and I come from an area surrounded by Latino physicians and scientists and work all in Spanish. So really leveraging this perspective, I think is really important and for me to say before we start. So now to the good stuff. What I also wanted to take time to talk about was, while I'll be focusing on sort of the biomedical viral load suppression, retention outcomes in this data, I also want to point to a couple papers that we've published recently, which really look at the social and structural factors. I won't go into them in detail here, but in every study, we try to carve out resources and time to try to answer some of the more complicated problems. So I'll point to a couple papers that I worked on with a former TAPS fellow and postdoc. Is the top one's an intersectional analysis of what it's like to be undocumented, language barriers, sexual gender minority identified in San Francisco receiving care. I think it's a great paper there. Really proud of the group in this one. The one below is about housing, the important role of housing between English and Spanish speaking trans women. The next two are about thinking more about the social economic factors that drive that affect interventions to promote HIV care engagement, as opposed to focusing on culture, which I think is now outdated and has some problematic issues to it. Another paper we published in Journal of Infectious Disease with my colleagues who are on the call here, thinking about the disparities of COVID with this national probability-based sample, the data were telling us that Black and brown people weren't doing anything different than their white colleagues, but yet you saw the disparity there in COVID. So again, this is pushing back and contesting against that certain behaviors drive disparities other than social and structural systems. And then the last thing we did was also kind of contest this idea around how Latinx people, whether or not they somaticize depression, which they don't, which is a kind of an unchallenged assumption that I was trained to think that has gone on for a while. Luckily, it's on the verge of changing, but we analyzed 15,000 PHQ-9 scores in this study and showed that that wasn't the case. So all that to say, I really think about these structural and social factors as well. But one of the things I wanted to talk about was just to start off with is ART adherence and viral suppression. So here's the big picture. Here's what we know. Latinx people in the US, 17% of the population, but almost 30% of new infections. Importantly, at minimum, at least a third of the new infections are Latinx people who were born outside the US. And we have overwhelming data to show that your place of birth is an indicator of your language proficiency, so English. So it has implications for who's accessing and who's benefiting from treatment. The MMWR report last week suggesting major disparities in PrEP awareness and PrEP referrals. And then on the bottom are the three primary outcomes on the care continuum. 74% of Latinx people are linked to care, 59% are kept in care, 65% are virally suppressed. Luckily, these disparities have narrowed, but they're still suboptimal. And so as a health psychologist who comes from training and thinking about depression and adherence, I like to show this slide because the data on the left is from 96, but really the data is from 83 to 91. And then the data on the left is from 2020. And the point estimates are not the critical part here. It's basically they're telling the same story, that people living with HIV with depression have faster disease progression and twice the odds in this case versus those who are chronically depressed versus not depressed, twice the odds of all-cause mortality. We've known this in 2001 with really large HIV cost and service utilization study. We know this with more recent cohort data, 1 in 2 people living with HIV depression. Multiple meta-analyses have shown depression leads to non-adherence. And so it's really, the puzzle for me is trying to figure out how all these things go together. How does depression go together with adherence when we're seeing these narrowing disparities? And, what role does ethnicity play in this? And are there disparities? So published 3 different papers, essentially trying to answer this question of given that the disparities have narrowed, but we haven't made gains in reducing the prevalence of depression, does that still factor in? And luckily, I think rightfully so, that is still a target to be focused on. In the first paper, we showed that, Latinx compared to non-Latinx people. clicked the wrong way. Up top here, the top paper that Latinx people living with HIV compared to their white colleagues had 1.8 times the odds of reporting missing at least 4 doses of antiretroviral therapy, which we think is a more ecologically valid measure because you can miss it intermittently and still have enough drug concentration to protect you from viral rebound. The next analysis, we analyzed a little over 3,000 patient observations in the CFAR network of integrated systems cohort. Kind of found the same thing. Depression is still prevalent, still affects adherence, but we didn't find an ethnic difference. So it only kind of complicates this puzzle here. And in the bottom paper, what we did was, in all the studies around adherence, people are trying to figure out what are the major targets to focus on. So we did a unique analysis where we analyzed commonly reported reasons why people tell you they missed their doses. And then we put them through this analysis that empirically derives rankings of what is, a more important barrier to focus on. And depression again pops up. So what's interesting is this analysis has gone on to spawn many studies from it. But all this to say, I was getting concerned. I was like, we're seeing these major improvements of viral suppression, but we're not doing anything about depression. Is it still worthwhile outcome to focus on? And I think it is, given the data we just saw. So that was like early data talking about adherence. We wanted to step back and now think about retention, because for the HIV folks here, we know that ART adherence and viral suppression are now nested within the retention step. So with my colleagues Mallory and Kat Christopoulos, who had a NIMH R1, again, along the quantitative psych area of measurement, they want to figure out, how do we measure people who are at risk for falling out of care? And the argument here was that retention is not the same as engagement, though the two words will be used interchangeably in the literature. Retention is whether or not you showed up to a clinical appointment or whether or not you had your viral load drawn. That doesn't tell you anything about engagement in whether a patient is informed, collaborative, committed to their care, satisfied with their care. And so this led to a study that I had a diversity supplement on, where the goal was to create a measure of engagement that you could give to patients. It's self-reports, 10 items, and higher scores mean that the patient perceives a higher level of engagement. So this is the definition, the working definition of engagements, the interaction of patients and providers, the care setting that's characterized by a sense of connection and participation in care. And multiple papers have come from this. So they validated the 10-item measure cross-sectionally in the CFAR cohort. Then we looked at it prospectively. So give somebody give somebody the index. 12 months later, it can predict viral load suppression or not, and appointment attendance. And then for me, the question was, well, does this perform the same in Latinx folks versus non-Latinx folks, which is a area of psychometrics called measurement invariance, that if you're going to be wanting to make cross-cultural comparisons or cross-language comparisons, you need to make sure that the measurement is robust. And so we have these statistical techniques to estimate whether or not there's balance in that measurement. And there was, which is great. So, and I think importantly too, we use this time to translate the index into Spanish. But then again, we use an incredibly robust process because we understand the importance that language has, right? Any error that you have that's purely a function of the bad language or the translation, it's just going to inflate, your standard error is going to affect your analysis. So we really take the time and understanding the importance of doing this work in Spanish to, and it takes resources and a lot of people to do this well. But we have this in Spanish, which has led to now the index is being launched at a East LA clinic. It's a Latino serving community-based organization. So that's going on right now. And that's through an Emory CFAR award that I have. With my colleagues, Pari and Karine, we have index data from younger folks. The original study was a lot older folks. I think 50% of the sample in the original studies were over 50. We have about 300 youth who are 18 to 29. I'm presenting data on a way to identify a shorter version or even quicker version of the index, because we think that if clinics can quickly assess how engaged a participant or a patient is, and whether or not they have high or low levels of engagement, that could trigger, immediate support to make sure they don't fall out of care. So we've winnowed down from 10 to 3. I'll be presenting on this data next month. And then with our colleague Kat Christopoulos, we're looking to launch the index in Spanish and in English in San Francisco, Atlanta, and Chicago as part of a long-acting injectable. So, you know, what started off as this one project doing this work in English and then getting it translated in Spanish has led to the collection of new data, the representation of Latinx people in this work. So I think that's important. But now to interventions.
John, can I interrupt
Sure.
for a second? Is because engagement in care is really applicable across all chronic disease, right? Not just HIV. So I'm curious, is this instrument, could it be used in other settings, or are some of those questions really specific to HIV engagement?
No, you've
Have you thought about that?
Yeah. The team has thought about that. I don't think we've made any, I don't want to speak ahead, but I don't think we've made any inroads in adapting it. But yeah, it's about, you know, not only the provider relationship, the clinic relationship, the individual characteristics of the patient and their ability to kind of see things through when life circumstances get tough, totally adaptable to a different context and setting. So it's definitely, yes, future directions there. Thanks for that. So that's around measurement, right? That's I think for me, thinking about how do we measure this idea? How do we measure it in Spanish? How do we measure it? And how do we look for disparities in Latinx groups? So a lot of new exciting data, I think, are on their way that I can hopefully present on in the near future. But now to interventions. So this is the K01 award that I had that is a no-cost extension. And for full transparency, totally behind schedule, totally not working, primarily because of COVID. It threw a monkey wrench in everything. And then before that, there was this IRB delay of about a year. So, but we're still pushing ahead, trying to collect as much data as possible. So, but the logic, I think, is important here. So I worked on an R34 initially, and I served as a psychotherapist where we were giving folks cognitive behavioral therapy. These were Latinx people in El Paso, Texas. We're giving them cognitive behavioral therapy to treat their depression and improve their adherence. They were also getting a specific adherence intervention as part of this program. And we were giving them this electronic pillbox reminder system. And then they were getting this really, you know, robust cognitive behavioral therapy program. So a lot of things going on in this intervention. And, you know, we found generally that people had better adherence and self-reported depression, but not necessarily clinical, clinician-administered depression. Clinician-assisted assessments of depression. So a blind rater did not detect differences in depression, but if you ask the participants, they were reporting they were benefiting. But in the study, you know, most people didn't finish the study. A lot of problems with the homework, which is essential in cognitive behavioral therapy. There's homework that facilitates the processing of the information and then practicing that information. You know, some participants gave the pillbox back, which I think is an indicator of whether or not this was useful. And in my, you know, to me, it was like, this is a lot of content, and can we make the intervention more efficient? And this is also expensive. Is there any way we can unpack this? And so with the K01, at this particular time, the NIH was calling for alternative designs, sort of tailoring interventions to the patient, right? Personalized medicine and the intervention, personalized interventions. And so this is a priority of the NIH. And one of the frameworks that they called for is what's called the Multiphase Optimization Strategy. So it's a family of trial designs that you can use depending on the type of research question that you're asking in intervention science. So what we did is with the K, we proposed a pilot sequential multiple assignment randomized trial. Most people have heard of it as SMARTS. So SMARTS is the experimental design, and the goal is to develop an adaptive intervention. And so this is out of Ward 86. Essentially what I did was I tried to unpack that R34 to some of those components. So I'll walk you through the figure. So we take Latinx people with depression at Ward 86, and we randomize them to a briefer version, the first part of cognitive behavioral therapy's behavior activation. And they either get that or they get behavior activation with text message support. And this is to solve that problem of homework, that people weren't completing homework. So this is to provide support during the week. And then we measure how they're responding to treatment. If they respond well, we keep them going. If they don't respond well, then we can think about augmenting the treatment. So for those who didn't get text message, let's add text messaging. If somebody got text messaging and the behavioral program and they weren't responding, then maybe let's think about bringing in the cognitive components to think about work on the negative self-thinking, self-thoughts. So this is the design, and we're just, we're unfortunately really behind schedule. We have about 8 people enrolled right now, and we're working through it. Luckily though, everybody's responding, and so that's telling us that it's working, but we're just having trouble kind of catching up with our numbers. But this pilot data led to the first R01 with my colleague Julia Lechuga from the University of Texas at El Paso. I trained in El Paso, as did Julia. We had the same mentor. We're here, El Paso's here in the West Texas border across from Ciudad Juarez in the state of Chihuahua. It is a place that's near and dear to my heart. I think it's beautiful, it's vibrant, and it's 85% Mexican is the population, Mexican American there. So in the border region, it is truly sort of a border, spiritually it's borderless, but obviously there's a border, as you can see here in this picture. It's expansive. There's 2.3 million people here, and for all the great things about it, unfortunately, Ciudad Juarez is a corridor for illegal drugs, 4 times the injection drug use rate of national average of Mexico, lowest rates of viral suppression, and 90% of people living with HIV in Chihuahua, in the state of Chihuahua, are in Ciudad Juarez. So, El Paso is underserved on the Texas side, and so with my colleague here who had a U01, sorry, this is from the NIMHD, she was working with people who inject drugs and people through a harm reduction program. So we got together, and she was part of the CAPS VP program. So we leveraged her harm reduction intervention for people who inject drugs, with my KO1 that was working on depression amongst Latinx people living with HIV, and then this pilot study looking at people who inject drugs, their adherence in Ciudad Juarez. And so we wrote this grant together where we were building on this literature that we know that people who inject drugs have the hardest time with adherence and viral suppression. So we know that reoccurring drug use is a problem. So we propose medication-assisted treatment to address this issue, which is beneficial for viral suppression. We know that people who inject drugs living with HIV have poor engagement. So we propose patient navigation. Again, there's a benefit. And for those who struggle with adherence, we propose an adherence program. And for depression, we're using the same behavior activation therapy program that I was using in my K. And this is also built on this really large multi-site trial, HPTN 074, which were people who inject drugs and their partners, where they offered essentially the same package of ingredients plus booster sessions. But again, the logic for us was that there's 2 options to go. The first option is to combine everything into one intervention and test it in an RCT. So you kind of put everything into this black box, and then you evaluate it and whether it worked. Now, there's nothing wrong with this, by the way, but the limitations are, if this doesn't work, we don't know why it didn't work. And if it works well, we don't know why it worked well. Is it the synergy? Is it one unique component? And so what we proposed is, what I think is really exciting is this new framework. It's a new way to think about intervention science where, and I'll quickly walk you through this, where you think of an intervention as, you design interventions like an engineer. You draw out your map, you make sure your logic conceptual model is tight. You then run experiments to optimize all the different parts. You would never design a product that costs $20,000 per person because it's not scalable, it's not efficient. So you take into account cost, scalability, the skills of the people, and you continue to reiterate on this process. And it's much like developing an iPhone. We don't start at iPhone 1 and then, that's it. We continue to refine to make something lighter, stronger, and more efficacious. So you apply this logic to designing interventions, which is what I'm really excited about.
John, can I ask a question here?
Sure.
So is the R1 then to develop the intervention, develop and refine the intervention?
No, so the R1 is to run this second phase called the optimization phase. So we're running a trial. And this trial is to optimize the 4 components I was talking about: medication-assisted therapy, depression, treatment for depression, patient navigation, and adherence intervention. Rather than give everybody all of those things, maybe only one, or maybe the interaction of 2 is going to get us to the goal we want. So that's the idea. This design allows us to test those things in that specific way, which I'll get to in just a second.
Interesting.
So some key partners here. Incredible partners, advocates, longtime, supporters of this work. I also want to shout out Maria Elena, social worker who's been there since the 80s, saw the first case as well in Ciudad Juarez. She's a partner with us. This is the primary site. So I'm just excited to be working with people who are, kind of dedicated to helping this particular population of Mexicans who inject drugs. So here are the aims. As I mentioned, we're taking these 4 components and we're testing them in a factorial experiment. And so I'll show you what it looks like. Oh, there's some more pictures, forgot, of our team members there. So this is our conceptual model. So we have these 4 components on the left that I mentioned. We have specific targets that we want them to affect. Ultimately, that's going to lead to reduced drug use, reduced depression, better adherence, better feelings of engagement. That ultimately lead to achievement of suppression over here on the far right, and then sustained suppression. So we've mapped out how we think the intervention is going to work. And we have our analysis built on the ability to test these individual pathways. So it'll tell us whether or not our model is wrong, it's falsified, or we can confirm it, which I think, again, brings insight into really unpacking and understanding how an intervention works. So this is what it looks like, the factorial design. We randomize people to 1 to 16 conditions on the left, and they get either, so person in condition 1 gets everything. A person in condition 2 only gets 3 out of 4. And when you fill up these cells with data, what you can now do is test the individual effect of, medication-assisted therapy versus patient navigation. You can test the interaction of them. You can test them in combination with other things, which give us a more nuanced understanding of how to affect sustained viral suppression, which is, can we help people sustain that viral suppression at 6, 9, and 12 months? And so that's what we're doing. We're looking at the different combinations and try to understand not only can we hit this target, but can we hit this target because we've also baked into the intervention economic efficiency and scalability constraints. So I'm pretty sure we're not adding anything that's not already occurring on the ground, working with staff qualifications, personnel there. So that way it's just a reorientation of prioritizing the plans and the systems that they have in place to support people who inject drugs already. So that's what I'm really excited about. And so in summary, I think mental health, substance use continue to be important drivers to work towards. I think it's incredibly important that if we're going to be doing this work, making cross-cultural comparisons, doing this work in Spanish, that the measurement and the science is robust and giving it the attention and resources that it requires. And also, recognizing the kind of history that this particular population has experienced around exclusion, lack of resources, lack of attention, and bringing the robust science with that attention, I think, will lead to the greatest impact that we're going to have. So what I'm also really excited and to randomly shift is to, this opportunity that came up to work in the HIV Cure space, applying the same principles. So quick story here, UCSF was planning a social science conference for the Center for AIDS Research. So this was a big social science conference that we were hosting in 2017. I, along with plenty of other people on the call, were on the planning committee. And we were designing the theme of the conference. And at the same time, had randomly gotten this 2-year fellowship from NIDA at Fordham University to develop an empirical research ethics project. So all the signs were there. Mission Hall, where I'm based, is also home to the Amfar Institute for Cure Research. And when I was learning about Cure Research, I actually saw how excited everybody got when thinking about like the issues around cure research, and that social scientists are not present in this important area. And so I got partnered with my colleague Corinne Dubé, who's now, we're co-pilots in this work. And as a novice, but as a health psychologist, I was asking, why in the heck would anybody join a study where you have to stop taking your HIV treatment? This, as a purely as a psychologist, like, this doesn't seem rational to me. And that sparked a couple of ideas here around, all the current ethical and social issues in the cure space can be solved by our methods, right? You're thinking about asking people to tolerate really intensive procedures. You're talking about third-party consent where there's now risk to a participant's partner. How do you solve that dilemma? Consent understanding, these protocols are complex and intense to people. How well do they understand them? And then scale up, right? There's an article that just came out a couple days ago talking about racial issues and how a cure won't matter if we don't fix, trust in public health, trust in science. And so what we wanted to do was create an empirical base for solving some of these problems. So it is also truly one of it's the most fun I've had as far as a multidisciplinary team, working with my biomedical investigators, with our community partners, all working in lockstep to support this. It truly is a multidisciplinary family here. And so some background for those who are new to this, cure is potentially scientifically possible. There's multiple strategies, likely a combination of different interventions are going to get to long-term remission without taking medications daily. That's essentially the goal. But there's less research on who a cure is for, and there are unique trials. There's unique challenges to in HIV cure trials. And so we've published a lot with my colleague who's spearheading all of this, thinking about how do we define cure, how do we consider diversity in cure trials, what are the agenda and the priorities to consider in the cure space. And importantly, there's no data on how people living with HIV go through really long treatment interruptions. So, these are months, almost years at a time when people are not taking their treatment. Close monitoring, but still off treatment. So importantly, I think the big key issue is the analytical treatment interruption, or the ATI. Unlike viral load, right? There's no clear biomarker for a cure. So we can measure viral load, and that tells us how well HIV treatments work, but we don't have a measure for a cure. And so we have to ask people to stop their medications and then monitor them throughout. And it's important in this statement in the Lancet, there's clear sign off on that we need to monitor participants' experience throughout this period while they're off treatment in a study. So again, as a psychologist, I was like, this does not seem rational to me. How do people weigh the risk benefits? How do they consider this information? Again, it's about measurement, it's about psych principles. And so shout out to this really quick study that we did. I got to exercise the psych muscles that we don't really get to do so, right, in a medical school, where we recorded 84 people living with HIV online and in person. And we designed a consent form based on this decision-making theory that is supposed to help people manage risk information. And we randomized people to read a standard consent form or an experimental consent form, where we gave them support to provide the bottom line meaning of really complicated language that's in consent forms. And we were wondering, if you provide people with this new type of consent form around stopping treatment, does it change their attitudes? Does it change how much they understand about the study? And does it change whether or not they would participate in cure research? And so take home point in these 3 green circles on the left is that when you give people this new way, this new framing of a consent form, it promotes better understanding, better attitudes, both thinking that it's safer, that it's a smarter choice, and feeling better about that choice is sort of the affective evaluation. But when you look at what actually affected their decision to participate, it was actually just how they felt about cure, like being really excited, which poses a lot more scientific questions to us. So in 2 studies that were done in 2 different trials where people were asked to stop their treatment. On the left here, led by my colleague as well, 19 participants noted a direct benefit, which is incorrect. 1 in 5 reported no risk, which is also incorrect, and about a third reported some anxiety about going off treatment. And then on the right setting, 5366, 6 out of 29 people reported no risk. Again, that's incorrect. And 17 out of 29 reported direct benefit. Again, that's incorrect. There's no direct benefit. There's a social scientific benefit, but not a personal benefit. So there's a lot of work to be done. And what's also important is, because this space is so new, being a part of a team that really is setting the agenda for thinking about, how do we do ATI trials in COVID? How do we develop a plan to protect partners for people stopping treatment? What is the role of altruism? Are we capitalizing too much on altruism? And then some other agenda items around what's the future of cure like, and are we prepared to deal with those issues? So that led to, lastly here, the NIMH R01, where we've nested various surveys that specifically measure issues around consent, understanding, motivations, anxiety, and also coping skills, strength-based measures across these 7 cure trials that are going on or planned to go on across the US. And we had to pull data because if you see the ends, they're relatively small. So we've integrated our survey data into these 7 trials, a couple here unique to UCSF. As I mentioned in AIM-1, we're getting baseline data about motivations, their understanding, to kind of characterize the landscape. But what's more interesting is here at UCSF, because of our colleague, Stephen Michael and others, we're going to be able to interview folks before, during, and after the treatment interruption to understand that nuanced process of what it feels like. And particularly answer some questions around stigma. People think that cures are also going to have grand implications for how people deal with HIV stigma. So in AIM-2, it's a quantitative aim. We're going to model the trajectories. We're going to capture what the psychosocial experience is like, again, before, during, and after these really long ATIs, which I'm really excited. And then we're going to try to predict where people start and where people end up as far as their psychosocial outcomes during these trials. And lastly, I apologize. There was there's an aim missing, so I apologize for that. But we're also doing a consensus building technique where we're going to bring around 60 experts, community advocates, regulators, biomedical investigators, social scientists, scientists who deal with racism in medicine, to try to solve some outstanding issues in the cure space, which is AIM-3, which I'm really excited about. So lastly, in this summary, and to summarize the work, I think, making inferences about group differerences or the experience of a particular person going through a particular trial requires sound measurement. And that is something that that excites me. It's something that's challenging, is how do you do this? How do you do this well? But that area of health and quantitative psych has allowed me to kind of navigate and move across these 2 fields. Think whether you're talking treatment or you're talking cure, mental health is an issue, whether it's depression in viral suppression, whether it's anxiety in cure research trials. And I think that for social behavioral scientists, we can really, with these methods, what's the most exciting part is to be able to advance science and thinking about sustaining these treatment gains and making sure that cures are scalable, that we understand what people want, their preferences, so that we can maximize the benefit of these future strategies. And so with these methods, we've been able to I've been fortunate enough, and with all the brilliant people around me, which is a given, been able to kind of navigate and move into these 2 spaces, where there's a lot of exciting data that we're looking to collect. And so with that, there's a bunch of people and plenty more to thank who have supported this work and me for all those years. So with that, I will stop and answer any questions.
John, thanks so much for a wonderful presentation. That's really amazing work. And I believe we have a couple of hands up and one question that came up in the chat. So Judy, I'm just going to have Patricia's question come up first, and she came first. Patricia's question was, how about questions around people's sense of identity? I think that was related to the last project that you had described.
Sure. Yeah. And I see Judy Albrecht's hands up, which is, all praise to Judy and her advocacy for this work, which is very much in line with that question. Judy and others published a paper in, I think it's 2015, around some of these issues, right? If someone's cured, what happens to their HIV identity? I mean, there's a lot of implications for it, but does it get rid of stigma? What if someone's just on remission for a year? How does that deal with stigma? And so we don't have the answers to those questions. But what we're really excited about is for the first time, we're going to have data from people before, during, and after these trials. Right now, all the data around what a cure would mean or what their experience was like was after they have exited a study. So they've gone through a trial and then they've asked to reflect on it, or they're giving opinions or thoughts about what the future is and how this could play out. But we're going to get data, across the trials, which is really exciting. So I hope to have some data to answer this question. But yeah, it's critically important.
Judy?
Thanks so much. John, I'm exhausted and I'm thoroughly impressed by the prolific nature of your accomplishments to date, considering I believe you're still assistant professor, but the amount of research projects and publications is just astounding. So mazel tov to you. Congratulations to you. The question I have is actually on the non-cure stuff related to research around mental health, the trajectory from mental health issues like depression, how they influence engagement adherence to antiretroviral treatment, to then influence viral load suppression and sustained viral suppression. And what I'm wondering is are your projects or are you aware of literature that kind of goes full circle and comes back to after sustained viral suppression? What do we know about the mental health of persons on treatment? In other words, does viral suppression contribute to a decrease in depression amongst the populations you're interested in, for example? And part of this comes from a place where I think a lot of us have been for a while, which is that the notion that viral suppression is the end all be all in the lives of people with HIV is problematic. It's the end point for most of the care continuum discussion, but there's additional quality of life, health and happiness measures that we think actually matter to people as much, if not more, than viral suppression. But I'm just wondering in your own work, if you're doing that full loop.
Yeah, that's a great point, Judy. And I hope that came across with the first slide to say that, right, I understand that the funding is for biomedical health outcomes, but creating space to answer and try to get more data on the more nuances, the intersecting issues, the social structure issues, the quality of life issues, which I think are so incredibly important. So yeah, we have one unpublished analysis. We presented on it at a conference, but it's not yet published, where we were showing that the longer somebody is engaged in care, you see reductions in their depression overall. So whether or not that's the treatment or whether or not they're just getting healthier, I don't know. That's, I think, an interesting question to ask. I honestly do not know the answer to that question, but I think it is definitely solvable with the amount of large cohort data that we have, where we can look at sort of baseline, where they started, where they are currently. But yeah, I think the expanding of the outcomes, to me, you're preaching to the choir here. I think it's incredibly important. And so thank you for always, reminding to orient ourselves to that kind of that guiding star too.
Thanks, John. I see Susan's hand up.
Hi, John. Wonderful talk and wonderful research that you've been doing. It's really great to see you thinking about the kinds of things that Judy always reminds us about. I'm wondering about, the relationship between depression and adherence, and I'm wondering, do you know anything about if it's related with PrEP? That people who are on PrEP and a lot of young men of color, young gay men of color, deal with depression. And I'm wondering, is it the same thing that we might be encountering with PrEP, that they're not very good at taking the medications consistently?
Yeah, Susan, thanks for that question. One thing I will, flat out say is I very limited knowledge of the HIV prevention side, aside from kind of the epi data around these disparities. But I don't really do work in PrEP, so I honestly not the right person to ask that question, unfortunately. But I do think what I am particularly interested in, and what our data shows with the depression and adherence literature, that it's important how you measure adherence. And for us social scientists, we use self-report measures of adherence. That's our gold standard. It's easy to use, and we're always going to use them. But I don't think that should also mean that we don't create the most ecologically valid measures of adherence. So it's not whether or not you forgot to take your PrEP one day or not. It's what is a clinically meaningful interruption in PrEP? And are we asking people to report that non-adherence or that adherence to PrEP in a way that is meaningful? So that way, when we think about depression, we can really refine our estimates to say, yes, depression impacts PrEP in this way, and it's meaningful rather than this person had perfect PrEP adherence and this person just missed one dose. Probably doesn't mean anything. And so for me, the importance is how you measure it and making sure that our measures are sound. But sorry, Susan, yeah, I'm unfortunately not that person to answer that question. I wish I was.
Thank you.
Yeah.
Hopefully I'm not missing anyone's, I think everyone fits on the screen. John, could I ask you a couple of last questions?
Sure.
With Michelle. So in your work, in terms, this is, from what I gather, a lot of the comparisons have been sort of Latinx versus non-Latinx populations. And I was wondering what your experience or findings have been within the Latinx community and sort of the heterogeneity and cultural background or beliefs in their relation to outcomes.
Yeah, no, that's a great question. And I didn't include that. I had a slide, but so unfortunately I took it out. Yeah, it's incredibly nuanced. For example, overwhelming data that, so it's about 1 in 3 or probably 1 in 2 new Latinx folks that are diagnosed today were born outside the US. If you're born outside the US, about 2 out of every 3 Latinx people who were born outside the US are not English proficient. So there's language barriers there. So you add all that up to think about HIV care outcomes. Overwhelming data that foreign-born Latinx arrived to care late. So late in stage 2 and 3, so CD4 cell counts really low, advanced disease. So they end up in the ER, end up really sick. So when they get to care, what we also find is they get to care late. So there's a disparity between foreign-born, non-foreign-born, but they actually really excel once they're in care. We have quite a few studies now to show that if you're a foreign-born Latinx, you have better health outcomes than your US-born Latinx folks and non-Latinx white counterparts. And 2 reasons for this. One of them is they think that if you arrive early on in an acute infection, you get a lot of close monitoring, a lot of quick linkage, a lot of other support. If you're foreign-born, you're probably more likely to get Ryan White services, which provides wraparound services. So you're getting a more supportive kind of intervention, and that's allowing foreign-born individuals to thrive. You can compare this to thinking about what we know from the acculturation literature as well. When you're trying to understand what happens over multiple generations in the US with Latinx, with their identity, with their health, and they start to mimic the average American in every way possible, as far as more depression, more drug use, more risky behavior. And so again, I think the common theme is like, I would love to spend a lot of time thinking about the dynamics of how someone's life experience changes, how their migration affects their health. And I think there's a lot of people doing that work. But yeah, that's an incredibly important nuance. For me, to make it simple, I tend to think about Spanish speakers as kind of falling into that bucket of foreign-born, maybe less familiarity with US healthcare system, language barriers, lack of mental health experience around sort of referral to service, engaging in that treatment. So that's one group. And then thinking about US-born Latinx folks as sort of a lot more opportunity resources for them. And so we kind of approach those 2 things, those groups in 2 different ways.
Got it. Thank you. And then I was curious in terms of the most intervention framework that you had described, and how participants are assigned to different, components of the intervention. Have you encountered pushback for, I noticed like one group would be assigned to like no intervention, and how you addressed concerns about that?
Yeah, that's incredibly hard. So for all the advantages that I've totally drank the Kool-Aid, for all the advantages that I think this intervention framework has, there's the limitations of the management, like just how do you manage that many conditions? But there's key experts who do even more complicated. So there's like 1 to 36 conditions, and they do these trials. So luckily, we've brought on a consultant who's done a more complicated trial just like this, who's given us the protocols and are just going to help us with navigating, managing, how you do that. Particularly, there's 2 issues I think you bring up. One is the contamination. People are going to talk to each other. Hey, you got 3, I got 4. What's up? I want this other one. Or you're getting, resources to go get methadone, and I'm not getting that. So it's just the realities and logistics of how do you manage that. And then with the group, it's tremendously important. So we've kind of waitlisted that bottom group. So after we've done our initial our full assessments at 12 months, then we will give that group those components. So they're basically being used as a comparator for a year.
Great. Awesome. Thank you.
Thanks.
Okay, a couple of new hands up. Stephen?
Oh, hey, John.
Hey, Steve.
Hey, great presentation. I didn't know all this context and this history of how you entered into this arena. So that was quite entertaining and useful and kind of fun. So one thing you didn't really talk a lot about that overlaps with HIV and with the Latinx community is poverty itself, and just being poor in San Francisco. And the reason this always bugs me is that a lot of people join these crazy studies that we do in HIV Cure. As you said, when people do things that just don't make any sense, like stop therapy. They do it because they're engaged in the science and they're altruistic and so forth. But others, I fear, do it for the money, right? We reimburse people for these studies, and we should, because they're incredibly time intensive and parking and everything else. And but we know, and we try to prevent it. But we know that people do some of the studies for the reimbursements. Are you quantifying this? What are your concerns around this issues, scientifically and ethically?
Yeah, thanks, Steve. So I would not say we're quantifying that in a way that, you could kind of do some analysis to kind of estimate that. We are collecting data on that, whether or not that is a significant motivator to participate. So that's one angle. And and I think you're right. What varies by site, and maybe with San Francisco, is just right, the cost of living, and that's a contextual factor that I think is unique here. Not other urban places have this issue as well. So I think there's that we're getting some data on that, to be able to characterize it, but I don't know if to be able to compare it to other motivators. Interestingly though, yes, I think there's a call for the NIMHD, what I think is fascinating, to understand the role of poverty and work, and how that relates to health. People who either work a lot or struggling with employment, and so there's this direct line to think about that. But yeah, I think I would argue that the bioethics folks or the social scientists who do ethics research would argue that people should have every right to make money from this study. I want to say that that's the guiding thinking on that. If you can make money from this, then why not? It's your time, it's your independence, your autonomy. But yeah, with the other studies that we pay participants at Ward 86, the money is a big motivator for whether they show up to a session or not for study. So I think it's a complicated issue, that requires further work. Unfortunately, I don't know if I have a great answer, Steve.
All right, well, let me know when you do, because we struggle with because we want people to be reimbursed for their costs and so forth, but we don't want to coerce them into doing studies, particularly studies that have high risk, and so that's always been a challenge for us. But thank you.
Yeah.
Thanks, John. I think we have time for maybe one more question.
Yes,
Alex, had your hand up for a bit.
Sorry, I missed the intros. I'm Alex Smith. I'm in Division of Geriatrics and Palliative Care, physician researcher. That was a very interesting question about the concerns about inducement and coercion. And I think you mentioned something that was really intriguing to me. Are we trading off too much on their sense of altruism in signing up for these studies? And I wonder if you could expand upon that a little bit and say what you mean. Like, are there limits to altruism where we should say to patients, you're doing, you're motivated too much by your sense of wanting to do good for others and future generations and contribute to the science, and you should really have a better sense of personal responsibility to yourself and not do this study? I mean, what do you mean by that?
Yeah, that's a great point. And I think where that came from was I seem to have multiple angles to every response. But in the study that we did where we randomized people to this new consent form or not, or the standard consent form, we also measured altruism. And if you look in the psych literature around what altruism is, there was this debate around, is it a trait that like you are inherently more altruistic than another person? Or is the most important thing is just whether or not you engage in altruistic behavior, right? So do you participate in the study because it's an important thing to do, or it's like you're just giving all the time and the study is just one thing? And so the measurement is tricky around this, which is kind of fascinating to me. But I will only say that I think my thinking on this is that it could be problematic if the altruism is so is overlapping the ability to appraise risk and benefits in an accurate way. And so in some of the data we had, we asked participants, do you think you're going to be cured from this trial? And again, it's a hypothetical trial, but it was a real consent form. And the people who said, yes, I thought I was going to be cured in the trial were the people who had lower understanding of the overall study. And then when you pair that with people said, I would participate in this study because I feel really good about cure and the idea of advancing science, that creates some tricky issues around. So I don't think there's anything wrong with super high levels of altruism. I think we have to be careful that that doesn't affect their ability to truly appraise that this is risky. Maybe this risk isn't the best thing for me. I think that's really complicated to do, but that was the thinking on that. I don't know if that gets at your point. As long as it doesn't disrupt the ability to process risk and benefits, I think it's okay.
Thank you.
John. All right, Susan, I still see your hand up, but I just wanted to make sure you didn't have additional questions. Okay. All right. Well, thank you, everyone.
Sorry
for
about
joining. Oh, no worries. And John, I guess we'll see you at the other link.
Okay, thank you.
Okay.
Thank you, everybody.
Thank you
Thanks,
so
everybody.
much.
All right.
The poll is still open for another moment or two. If you haven't answered yet, please feel free to answer our poll and we'll collect your feedback. Thank you.